Good evening, everyone. I'm Michelle Leifer, the director of the USDAN Institute for Animal Health Education at the Schwarzman Animal Medical Center in New York City. Along with my colleague, Valeria Menendez, I want to thank you for joining us for tonight's webinar, Anesthesia in Pets, Easing Fear, Explaining the Facts with Dr. Andrea Looney. So we know anesthesia can be a source of anxiety for many pet owners, and tonight's session is designed to provide clarity and peace of mind, walking you through what to expect and how veterinary teams work to keep pets safe and comfortable every step of the way. Before we begin, just a quick reminder, this webinar is for informational and educational purposes only. It is not a substitute for professional veterinary advice, diagnosis, or treatment. If you have concerns about your pet's health, we always recommend reaching out to your veterinarian. Tonight's event is being recorded, and we'll email the link tomorrow in case you'd like to revisit the presentation or share it with a friend. We'll be taking questions via the chat box, and we'll leave time at the end to answer as many as we can. I want to take a quick moment to mention our next event, which is AMC's 8th Annual Celebration of Life, taking place on Tuesday, September 9th at 6:15 p.m. on Zoom. You can find more details and register at amcny.org/events, and we'll include the link in our newsletter that goes out this evening. And now I'm honored to introduce tonight's speaker. Dr. Andrea Looney is a board-certified specialist in anesthesia and analgesia and a senior veterinarian here at AMC. She earned her veterinary degree from Cornell University, where she also completed a residency in anesthesiology. She later returned to Cornell as a senior lecturer in pain management, palliative care, and rehabilitation, and went on to teach at the Cummings School of Veterinary Medicine at Tufts University. At AMC, Dr. Looney brings decades of experience to our anesthesia service and a deep commitment to keeping patients safe and comfortable through every phase of their care. We are so grateful to have her here with us tonight. Please join me in welcoming Dr. Andrea Looney.
Thank you so much, Michelle. I'm just going to share my screen. And thank you, everyone, for joining me this evening. It's a pleasure to be here with you all. And I hope the presentation is satisfying to everyone. Hopefully, you'll get some questions at the end. Want to see if we can go ahead and just get into one view here. Good. Okay. So our objectives this evening, I want to go through some terminology regarding veterinary anesthesia. I'm going to intertwine that looking at some of the evidence, meaning some of the literature that's been out in the last couple of decades about anesthesia, morbidity, and mortality in our patients, and give you an idea of what's involved in the sedation and anesthesia of many different patients, and mostly our pets, and hopefully end up with some recent research that's relevant to improving anesthesia with some problematic species and breeds. Just to start out, we all have this fear of anesthesia, and there's several different types of anesthesia. Probably the semi-conscious types of anesthesia, that terminology that many are unfamiliar with, are the terms of sedation and tranquilization. When we tranquilize a patient, a veterinary patient, we try to take away their fear and anxiety. When we sedate them, that's actually coupled, that loss of fear and anxiety is coupled with a reduction in consciousness. And of course, general anesthesia is the full loss of that consciousness. It can be in the form of some injections that we give, intravenous infusions, or it can be in the form of some inhalants, which is actually liquid anesthetics, and we use the vapors from these anesthetics to maintain that unconsciousness in our pets that are anesthetized. Analgesia is a term that we use for the loss of pain. So our job as anesthetists is to take a patient, make them more tranquil, as we see here, and slowly over time get them into a state of sedation, whereby we take away that loss of fear and anxiety and couple it with a reduced consciousness. And then finally, if we need to, go ahead and place them under what we call full general anesthesia, where we actually intubate them, place a tube to carry some of those vapors and gases into their body and maintain that state of unconsciousness. There's also a form of anesthesia called local anesthesia, which many of you may be familiar with in terms of your own procedures. If you've had a fracture fixed or a dental procedure whereby an anesthetist would deposit a small local anesthetic around a nerve trunk or a region supplied by that nerve in order to lose the sensation in that area. Sometimes that's coupled with a loss of motion in the area as well. We're going to be mostly focusing what we call general anesthesia tonight when we talk about things, but I will cover some things on local anesthesia as well. So when we take our patients through this train of loss of consciousness into a general anesthesia state, we actually are titrating poisons in the body to allow that patient to have a loss of anxiety, an amnesia, hopefully, a loss of sensation, so they don't feel things, and then a reduced autonomic function. And that autonomic function, that's kind of the fight or flight systems of the body. We have to kind of attenuate them, but allow their functions to be easily reversed. But the basic premise is that we are actually intoxicating or causing a balanced intoxication of these body systems and hopefully bringing that patient back, having a reversibility by using a combination of injectable and inhalant agents. And a strange thing about this is that to this day, we have many theories on how general anesthetics work, but we don't have a proof that one or the other is working in particular in our or our patients' bodies when they're anesthetized. Most of the terminology, most of the thought process that we use in thinking about how general anesthetics do their work is based on the premise that they may reduce the excitation of certain neurons or enhance the nerves in our body that already suppress those autonomic functions, mostly through calcium and sodium channels, through a specific set of channels called GABA, G-A-B-A, and glycine, and hopefully even glutamate and aspartate channels. But again, these are all theories. And to this day, though we can put man on the moon, we still don't know the mechanism in full by which these anesthetics cause that physiologic reversibility. What we do know, however, though, is that general anesthetics, whether they're injectable or inhalant, are potent at reducing perfusion, oxygenation, and ventilation, among many other systemic effects. General anesthetics have effects in all body systems, even our immune system, liver, kidney, pulmonary, central nervous, cardiovascular systems. And these are very, very potent effects. In fact, they're what we call dose-dependent effects, meaning that as we get deeper and deeper into anesthesia, and our pets get deeper and deeper into anesthesia, we actually reduce those functions more and more. Not in an exponential way, but more of a linear and dose-dependent way. So we get this degree of organ dysfunction that progresses, and it's a fine line of how it progresses when we give these drugs. So we start out by giving injectable agents. When we pre-med a patient, we try to initially reduce their anxiety, their fear, their memory of the event. When we go ahead and induce them, meaning give them an unconsciousness, and then we maintain them with the vapors of these liquids, general anesthetics. This is the typical type of a protocol or plan that we use on every one of our patients. So patients start with kind of a tranquil state, they get into a more sedate state, a fine line between becoming unconscious with our injections and our inhalants. And then there's a fine line tipping point at the end whereby that titrable poisoning can actually overdo it. And so that's, of course, what we as anesthetists and anesthesiologists try to guard against, at the same time trying to make sure that our patients are not feeling anything, moving so that the surgeon, the proceduralist can do their job, and having a reversibility in all the depression of that central nervous system. But it's a well-known fact that the more sedate the patient gets, the greater the pathophysiology. And there's been a number of significant complications that have been noted in anesthetized patients, and the same is true for human patients. Probably key amongst them, we don't ventilate or respirate well when we're under anesthesia. We have low blood pressure. We give our patients low blood pressure under anesthesia. Heart output, cardiac output is definitely reduced. Our patients tend to lose on average 2 to 3 degrees of body temperature. So these are all well-known effects. And our job as anesthetists is to guard against them and try to minimize not only those consequences, those ill consequences from anesthesia, but the entire downtime, which is the time that that patient truly is unconscious. And in that period, we're acting as a constant, vigilant shepherd of that patient's autonomic physiology and sensory and motor physiology to try to maintain that fine line and take that patient to that place where they don't feel things, don't remember things, have a loss of anxiety, but be able to bring them back. It's a scary thing because we know that volatile anesthetics or inhalant anesthetics really can act to neuroprotect our patients, which is great. Interestingly enough, much of this is done through a small enzyme called nuclear kappa beta enzyme, BNKB. But it is a fine line when that depression of that central nervous system, whereby the body is protected, actually starts to work against itself and becomes more of a toxicity. And that's, of course, the place that we sit as anesthetists to protect your pet under anesthesia. And it is a very fine line, with many of our patients made even more fine by the fact that most of our patients are not healthy going into anesthesia or surgery or procedures. And many of them have very specific species or breed predispositions that we need to look out for. So when we have a patient that goes from being tranquil to sedate to generally anesthetized, who performs that on your pet? Well, 9 times out of 10 in a general animal practice, anesthesia is performed by certified and licensed veterinary technicians who work under the direct supervision of a veterinarian. And they have a procedure to anesthetize patients that is very little modified. And the drugs and techniques are usually decided by that practice's doctors and nurses together. And this works extremely well in most practices. And many of these technicians and doctor teams, because anesthesia is a practice of familiarity, of routine memory, of repetition in terms of quality practice, that most of these patients do extremely well and the procedure goes very, very well. But we do know that the success of anesthesia is not based as much on having a patient just come through surgery or waking up or having them get through a procedure. For the profession, thankfully, that has not been good enough. And we have done a great job over the past 20, 25 years in the time that I've been through residency and out in coming up with safety standards on how we actually provide that vigilance through anesthesia experiences. So much so that internationally there's standards and guidelines out about the drugs we should use, the monitoring that we should give that patient, the supportive care around that event, how we should recover them, and even to the point that how individuals should be trained in order to provide anesthesia. So there's many of these what we call standards of care that are out there, that are freely look upable online and very worthwhile reading. There's also a number of incredibly good organizations that are out there that have promoted not only the practice of quality anesthesia, but also the recognition, treatment, and prevention of animal pain, which is an extremely important part of what we provide as anesthetists, surgically and procedurally. So these organizations are out there and they do just a wonderful job in promoting the specialty in and of itself. Now, in practices that are usually specialty or emergency, technicians can go on to become what they call veterinary technician specialists in anesthesia. They go through a process whereby they accumulate a number of cases. They critically examine and write these cases up. And they also go ahead and take a test at the end of attaining a certain amount of necessary skills to advance anesthesia within their practices. These are called VTS anesthesia technicians, and they are extremely well trained in the practice of just anesthesia. And there's many different specialties they can be trained in, but anesthesia has utilized these people amazingly well. Even beyond that, most academic, specialty, and veterinary teaching hospitals like AMC are very fortunate to not only have a number of these VTS anesthesia technicians or technicians that are even at that level, which is fantastic, but they also has veterinary anesthesiologists. I'm very fortunate to be part of the staff at AMC with 3 other anesthesiologists, and we are trained not only in the practice of small animal anesthesia, but anesthesia among several different species and more difficult cases, as well as special needs procedures that come up at a specialty hospital. And I think a big benefit of having us there is not only that we can streamline the processing of these patients that come in, let's say on emergency, and need imaging, and oh, by the way, they need specialized catheters placed, and then they need surgery to correct a problem that they've gotten traumatically or over a disease process. But that we also go ahead and we have that ability to communicate to each other and the other specialists on staff. And I call that constant training. But it's not actually that I'm giving something to someone. I'm not training anyone. It's just a continual feedback that leads to that improvement in all of our daily practices of anesthesia. So I think that's really a big advantage to a lot of the specialty hospitals that have anesthesiologists and VTS technicians on staff. Another big advantage is that treatment recognition and prevention of pain in our profession has really become a subspecialty in and of itself. And the anesthesiologists have taken some of that and gone even further to try to help treat chronic pain, which is a big area of specialty that I'm interested in and enjoy working in as part of AMC. So what's involved in the average anesthesia event for a veterinary patient? I thought I'd take you through this for most of our patients. You probably don't know what happens when you drop your patient off for a procedure or a surgery, and we take it from your arms and bring it back to the hospital. Really what we're doing is trying to assess that patient first off in terms of what history it's come with. So we have a lot of, I'll just say, research on the records that accompany a patient. We also look very heavily into the imaging of that patient to be sure we're not missing anything, and try to make sure that we communicate that well with your own doctor, as well as with you, as to ways we're going to go ahead and carry through that anesthesia of your family member. All that information comes together to help us decide what drugs and techniques that we would use in our patients. And we use a lot of the same drugs that they would use in human anesthesiology, particularly the opioids and the induction drugs. Sometimes we use them in different forms in our veterinary patients, but they're basically the same drugs. And we use the same gases that they would use for you and I if we were anesthetized. Our mechanism of getting them into your patient is usually initially through an intramuscular or intravenous injection, but we have to place catheters, IV or intravenous catheters in your pet following that initial injection to make sure that we have a lifeline into that pet to continue the process of anesthesia and to be ready for any emergencies that might occur as a result of the anesthesia itself. Now, while that sounds like a small process of getting an intravenous catheter and administering drugs through it, I can tell you that's one of the hardest parts of our jobs. It really depends on the species and on the breed, how easy it is. For instance, where we put that intravenous catheter, whether it's in a horse on the side of their neck in the jugular, a rabbit in their ear, or a snake on their mid-ventrum. We have a whole different process of getting that through the skin, in between the scales, around certain pieces of cartilage, on certain sides of the neck that are more accessible to others, on certain veins that are more accessible in all of our species. And then we go ahead and we do what's called pre-oxygenating your patient. Now, this is the part, if you were being anesthetized, where your anesthesiologist or nurse anesthetist would put a mask over your head and ask you to count backwards. For our patients, some of our patients fit right into our masks, which is very interesting. And some of our masks are actually very unique little contraptions. For instance, a lot of mice have masks that are actually very typical of a pen cap or a makeup pen cap. Whereas many of our smaller patients, such as the bat, can fit right into a mask itself. And some of the birds, some of the masks actually provide protection for us in terms of those strong beaks when we go ahead and pre-oxygenate our patients. We also have a way of MacGyvering a lot of masks. So certain species need a larger mask, such as this pig, and swine in particular can be really difficult to intubate. So we sometimes have to go ahead and create masks out of certain jugs, milk cartons, etc., that are capable of transmitting and pre-oxygenating those patients appropriately. How we actually get that patient into an unconscious state after we pre-oxygenate them is using that intravenous catheter. And we use drugs that are again, very typical of human anesthesiology. One of our favorite drugs is propofol, which is an amnestic agent, and a general loss of unconsciousness occurs whereby we're able to put a tube down that patient's trachea and continue the process of anesthesia using vapors and gases, which are transmitted through this machine. The idea with an anesthesia machine, as complicated and big and clunky as it looks, is to change a liquid form of anesthetic into a vapor that is carried by an oxygenated mix or an air oxygen mix into that patient, and to remove carbon dioxide from that patient and the excess anesthesia that they do not need. So intubating a patient, whether it's a cat or whatever, we use again the same endotracheal tubes that your anesthesiologist would use. But that is another very difficult aspect of our job because not all tracheas are as accessible. And a human anesthesiologist will tell you this is probably one of the more difficult parts of their job too. Unfortunately, because many humans have neck issues and getting our neck at the right angle to go ahead and intubate us can be pretty difficult. Same is true with our patients too, especially if there's pathology there. This is just a picture of a dog's open mouth, whereby we insert an endotracheal tube, which is the plastic coming in on the right, into that small black hole at the end, which is called the glottis, and it's the opening to the trachea. But there's, as you can see, there's a lot of shelves of tissue around that, made even more difficult by the fact that in pathology, those tissues become thickened. And then there's also a spasming that occurs if the animal's not at the appropriate plane of the loss of consciousness. So that intubation can be very difficult, especially in brachycephalic breeds, almost impossible. Certain cats and rabbits, again, almost impossible. And in fact, for rabbits, it's one of the more difficult things to do. And we often use a small scope that is put down the endotracheal tube. We also have to hold back the cheek folds on a lot of our patients so that we can get access to that airway and to that back of the mouth. Many rabbits have a very large tongue and make it very difficult to get into that area. So this can be a challenging situation. It can be even challenging in large animal species, even more so. Horses and cattle, it's a well-known thing that they are intubated with a lot of difficulty, as are ruminants too. And in fact, in cows, it's common to go ahead and have us put one of our arms into the cow's mouth after making sure that it is open and it's not going to crush our fingers, palpating the trachea itself and using the hand to guide that tube into the trachea. And today, to this day, that's done that way to intubate cattle. Pigs and swine are extremely difficult to go ahead and to intubate. And potbelly pigs, this is just an example of the tortuousness of their airways around these heavy jowls, as well as a lot of fat up in and around the neck, and very comparable to kind of a weightlifter. With very difficult neck to go ahead and to manipulate and to get a tube into that airway. Sometimes we have to go ahead and put these patients on their back, having 3 or 4 people go ahead and hold that jaw in a very particular way in order to guide that tube into that trachea. So a difficult thing to do. Now, in some species, it's actually a very easy thing to do, on the other hand. So in particular, birds and certain reptiles, once we can get their mouth open through that graded plane of unconsciousness, we can actually visualize that glottis a lot easier than in a cat and a dog. And in some species of birds, we can actually utilize things called air sacs to go ahead and deliver those vapors, those gas and inhalant anesthetics into their respiratory system. So it's not as difficult in certain species as in other, but it's overall a very big process of our job to do that. Following our intubation of that patient, the patients need to be moved into the appropriate surgical position. And this is nothing for a dog or a cat, but large patients, large animal patients, have to be generally lifted very carefully on heavy, heavy duty mats to be able to be manipulated into the appropriate position. And all this time, the anesthetist and anesthesiology team is making sure that that patient maintains life, that their autonomic and motor and sensory systems are working but are subdued. And of course, the patient is being protected from the personnel and personnel from the patient. And this can be even more traumatizing for a zoo patient in many, many ways. So the movement of these patients is a critical part of our job. It becomes more critical the larger the patient gets, and this is true for even large dogs. And the reason this is true is dead weight of these patients on their very precious organs that are critical organs, such as the myocardium, the heart, and the lungs, the chest cavity, can actually crush those critical organ cavities and create a loss of circulation and perfusion even worse than the actual anesthetics can. So we call it the recumbency can actually kill the patient, not alone, let alone the anesthetics having a depressive effect. So moving these patients is really a large part of the protection that we need to provide them. We then go ahead and instrument these patients. And when I say instrument them, we're hooking up what we call vital parameter monitors to these patients to go ahead and measure cardiac output, non-invasive blood pressure, ECG, blood pressure in many different mechanisms, pulse oximetry, capnography, all the terms, the monitoring allowing us to ascertain the critical organ system function, perfusion, oxygenation, and ventilation that we need to maintain life in those patients. So in the end, the patient being positioned on the surgery table, I would say a majority of the equipment in the room is for the patient's safety and the anesthesia process versus the actual surgical process. And that doesn't matter whatever size that patient is, we still need to go ahead and to monitor them appropriately. And this can be very challenging for certain species, such as amphibians. Sometimes the probe that we use just to measure heart rate or to look at oxygenation is often larger than some of these species are in and of themselves, which is crazy. But this is just an example of the monitoring systems that we would use. And these are the same things that you would use in your patients and in your anesthesia if you were being anesthetized for generalized procedures, colonoscopy, fracture repair, hernia repair, etc. So the process of anesthesia in large animal patients and small animal patients requires many, many people. And monitoring is a big, big part of that. And we now know, given the morbidity, mortality evidence that we have available, that monitoring truly does decrease our chances of having problems around the time of anesthesia. That's called morbidity. And of course, mortality, the chances of death around the time of anesthesia. The monitoring itself, though, I will say, is only as good as the personnel that are reading it and responding to it. And I think that's really where the beauty of having an institution like AMC and some of the larger specialty hospitals comes in is that, again, we're constantly getting that training and looking at these and talking about these variables. And that's an example of this is, we know that intraoperative hypoxemia or low blood oxygen, it's a rarity under anesthesia because we generally in anesthesia provide our patients with 100% oxygen. You can't get any better. So how does intraoperative hypoxemia happen? Well, because we have studied so much and we've advanced so much in the practice of anesthesia with VTS technicians and people that are at that level and the anesthesiologist, we now have point of care testing to look at how something as rare as hypoxemia can happen. We have instrumentation to go ahead and to treat it. And we also have the knowledge through figuring out different equations, how best to treat that in particular for that patient, that species, that breed, etc. And that's not something that we've had in the last 20, 25 years. The practice has gotten this good, and I'm just proud to be a part of that, especially at an institution, especially a hospital like AMC. We also, during anesthesia, we give your patient what's called a nerve block or a regional block. We insert that local anesthetic once they are unconscious around areas that are going to have surgery or procedure done on them. And this local block technique is become a fascinating area of interest of mine and how we can not only treat pain surgically, but chronically and use these blocks to treat pain chronically. Local nerve blocks and epidurals, we try to give one to every patient that goes through in terms of a procedure or a surgery. And we know that they not only help relieve pain intraoperatively, but they prevent that pain from winding up and becoming pathologic in the postoperative period, which is essential, I think, to an animal's recovery. So this has been well known in the human anesthesia field that local blocks can really help an earlier discharge of that patient from the hospital. And of course, they return to their life quicker. They have improved convalescence. And we are getting more and more data to look at that. And we think the same in veterinary patients as well, but we just need to prove that in the literature. The recovery process for our patients is probably one of the biggest areas of focus for an anesthetist or an anesthesiologist. And we recover patients carefully only because, by and large, this is one of the largest areas wherein mortality of our patients occurs. So peri-anesthetic death doesn't occur during anesthesia. It generally occurs post-operatively in this period. Recovery can be really tough on many, many different species. For instance, equine species in particular tend to go ahead and thrash and have quite a violent recovery. This is just a couple pictures of the famous thoroughbred Barbaro as he was recovered from his first surgery. And sadly enough, we've lost many large animal patients during this time period. It's not as critical of a violent issue in terms of our small animal patients, but still a critical period. And critical more so for many of our avian species and making sure that similarly they don't hurt themselves during that time of recovery. But this has been documented in our literature that a majority of our anesthetic mortality occurs in the postoperative period. And I have to say, looking at species and breeds in particular, this is one phenomenon that does not change. That postoperative 6 to 24-hour period is a period where we lose most of our patients. And so that's why I think, again, if you're having anesthesia done on your pet, it's very important to make sure that post-operatively in that period, they are going to be watched and critically evaluated for that return of that depressed cardiovascular function that we did with the not only the procedure with the drugs that we gave. The postoperative period is also problematic because it's accompanied by a return of that patient's anxiety and pain, a lot of GI signs related to the drugs that we have just given, as well as coagulation issues and electrolyte disturbances, etc. So this is a problematic area, and we really keep an eye on it. So in general, when we take an awake animal dog or a cat, and we bring them into this state, the success of this procedure has been really looked at critically in the literature over the last 15 years. And in fact, one of the landmark studies that looked at this was a study done in England by Broadbelt that looked at this in early 2000s and really came up with a list of factors that increase anesthetic mortality and morbidity. And one of the key features I really wanted to focus on today is that they found there was much more problem in anesthesia. And that problem, I would say, either illness from anesthesia and or death from anesthesia because of the health of the patient going into the procedure. Now we all know the success of anything will depend on the personnel doing it, the readiness for any emergency, as well as all the monitoring and drugs, and we just talked about, especially in the recovery area of that patient. But I want to look a little bit closer at that health status of the patient going into surgery and anesthesia, because I think it's something you as owners can really focus on at home in helping your pets get through the procedure. So we call this ASA status, American Society of Anesthesiologists status, and that really describes how healthy the patient is going into the procedure. And it's very predictive of how the patient comes out and whether they actually make it out. Certain body systems define that health more than others, like the heart, the kidneys, the airway, the neurologic system, in particular the brain. And we found that poor health of patients preoperatively really equals a high anesthetic risk. Now, human anesthesiologists classify this risk as 1 through 6 in Roman numerals, and we too do that in veterinary medicine. And there's been a lot of evidence, and I say a lot, incredibly good evidence in the last 10 years about how this health of the patient going into anesthesia predicts an outcome at the end of the procedure. Not only in dogs and cats, but in birds, in horses, in rabbits, and many, many other species. So one thing that we've seen is that when the animal is sicker going into anesthesia, the chances of having problems intraoperatively and postoperatively are higher. And we know that that sickness going into anesthesia can be something that we can really work on. The general anesthetic risk of death in dogs and cats, through many of these studies, has been determined to be maybe 1 in 400 to 600. Okay. And in human patients, it's 1 in about every 100 to 200,000. So we're not doing really well in terms of the risk of death. But look at what happens when the patient going into anesthesia is sicker. That risk gets even worse. So it's really something we need to work on. You've all heard about the famous saying, junk in equals junk out. So getting that patient healthy ahead of anesthesia can be very fruitful for getting it through anesthesia. The same is true for rabbits. The death rate jumps from 2 to like 7 to 10%, depending on where you read, in terms of healthy pets going in and non-healthy pets going into anesthesia. So knowing this all in terms of, and true for avian species as well. So unbelievable stats that we have. In terms of what you can do to minimize that ASA status or make your pet healthier going into surgery, looking back at my career, I can honestly say, try to invest in a very good physical exam by your veterinarian. Trust your veterinarian to do that. Probably more important than even the vaccines you can give. And consider regular diagnostics in that patient. And I really don't mean just blood work. Try to have the patient get some regular x-rays and abdominal ultrasound to truly look at that critical organ function going into anesthesia. We know that geriatric dogs, the screening of them, it has been proven in the literature that if we screen them a little bit more effectively, we not only can maybe not need their anesthesia because we may find the problem that we think we don't need to solve surgically, but we can also improve the practice of anesthesia in that pet by screening of these pets. And if you can, we know that age has not been fully proven to be a risk factor in anesthesia, but many dogs that are 3/4 of their life old, and that's going to depend on the breed, right? We don't have a set year that that happens, have an increased risk of problems around the time of anesthesia, usually again post-operatively. So trying to have that general anesthesia in that pet done in early life or midlife versus older age, it would be better for your pet. As well, try to become your pet's hospitalist. And what do I mean by this? Keep track of their medical information, the supplements and the pills that they get every day. It's so important for us as anesthesiologists and as veterinarians in particular to know about those because especially as anesthesiologists, we are kind of the creative pharmacologists. It would help to know what's already in that drink mix before we add something else. So keep track of that for us. And in terms of just an example of how prior problems in your pet's life can affect a surgery, we just recently anesthetized a 4-year-old retriever for what we call TPLO surgery for a knee injury, a cruciate ligament injury. Now, in asking the owner what problems the dog had early in life, they had forgotten, and reasonably so, that the dog had been hit by a car early in its life. And we didn't know that until we had the patient under anesthesia and had tons of problems getting the animal to oxygenate and ventilate well. And it turned out that dog had a torus lung lobe, which is something that really should have been corrected, earlier in its life, but the dog never showed any signs of it. But it did create quite a problem. We got the dog through the surgery okay, and the dog went back the next week to have the lung go ahead and be removed and taken care of. But just keeping track of that and making sure that, during times of illness and surgery, you mention that to your veterinarian can be very, very helpful. Interestingly enough, in all that literature about morbidity and mortality and anesthesia, urgency is linked to a higher complication rate. And that's been seen in a number of these studies. It tends to be worse in certain species. So if you emergently need an anesthesia, especially if you're a cat, it's not a great place to be in. And especially if you're a brachycephalic dog, it's also a really tough place to be in. So what if you can't get your pet healthy pre-anesthetically? And what if you have an emergency and that surgery can't wait? Well, this is where the larger specialty hospitals come into play in that we can really take care of these pets in terms of what we call optimizing or stabilizing those problems, those pets that are urgent, those pets that aren't healthy and need to go to anesthesia. What do I mean by this? We try to take a pet that has maybe chronic blood pressure problems like the cat on the right, or maybe has kidney disease like the cat on the left. And we're going to try to make that cat within a 24-hour period or less as kidney healthy, as blood pressure healthy as possible. So that going into that procedure, it comes out on the other end, and not only comes out on the other end, comes out better. And that's really the beauty of having a larger specialty hospital, the VTS technicians and the anesthesiologist, the criticalist on staff, as well as the number of other specialists that I'm very fortunate to work with at AMC, the cardiologist and the internist, et cetera. It really does benefit your pet in the long run. What else was linked to mortality and morbidity around the time of anesthesia in those studies? Well, one of the things that's worth mentioning, I believe, is obesity. Now, many of us in America have obese pets. I'm one of them, and I'm an owner that has that type of a pet. But going to anesthesia, there have been studies done to look at the impact of that on anesthesia. And there's even been an incredibly cool study done on anesthesia pre-weight loss and post-weight loss in our pets. And you can see from the data on this that when an animal weighs more, they have more of course, a body fat layer, but they have less of a volume of water distribution. And that affects many of the way that our drugs are distributed throughout the body, are metabolized, and come out on the other end. So not only do we know that if we can have our patients lose weight, they will do better, but we actually can predict our oxygenation and ventilation in those patients with weight loss. So we're that advanced in terms of our anesthesia. Now, the other side of the coin is if we have a patient that's really underweight, that's not good either, okay? And in fact, if we have a patient that's what's called cachexic, meaning dramatically underweight, we know that that really can predict a poor outcome on the other end of anesthesia. And in my time frame of practicing anesthesia, I can honestly say I've only dealt with a few animals who are cachexic going under anesthesia, dramatically underweight. They did not do well, but really what happened is we didn't predict what was causing that underweightness ahead of time. And if we had done that, the animal may not have needed anesthesia, but we may have done better during anesthesia. So we can score that body weight when we start to assess our patients to go to anesthesia. And as an owner, it really would be helpful if you can consider weight loss prior to the anesthesia of that pet. Now, sometimes you can't, okay? And the need for anesthesia is imminent. But if you have a species or a breed that is linked to high mortality, such as a brachycephalic, that weight management can be critical over time to help us get your pet through anesthesia. What about anxiety and fear in our patients? We know that the subspecialty of anesthesia and pain management has advanced so that we actually can grade these fear, anxiety, and pain in our patients well. We can score them pre-anesthetically. In fact, even given the species, based on their facial characteristics, we can score their anxiety and their pain, which is an amazing thing. And what we've learned is that if we can do this pre-anesthetically, treating that pain and anxiety as soon as possible, even prior to the anesthesia and surgery event, is going to be in that animal's favor. There has been a number of studies to look at treating that pain and fear ahead of time. It not only makes things easier on the patient intra and post-operatively, it decreases their chances of disease and death, and it reduces their need for that very, very dangerous gas anesthesia that we give. And the lower gas anesthesia, remember that dose dependency of gas anesthesia, the lower we get of that, the better off we're going to be for our pet in anesthesia. So the take home from this is if you have stress in your pet, and most of our pets are stressed going into a hospital, treat it ahead of time. Try to treat it even before you get to the hospital. We call that maybe the life is beautiful type of thing. You know, think positively until the absolute last minute you have to hand that pet off, because they can sense our fear, our anxiety around the event as well. Try to give those pets something maybe the night before, the morning of, and that's usually coupled with some anti-inflammatories and anti-nausea medications as well. Treating pain surgically, there's a landmark study that was done in the early 90s out of Boston that looked at a number of infants needing to undergo open heart surgery. And they classified these infants into two groups. One group they actually gave a as needed opioid when they started to grimace or club their hands during surgery. And the other group, they actually gave opioids ahead of the need for any type of surgical intervention. So at the beginning of the surgery. And what they noticed was the infants that got the as needed opioid had not only worse perfusion indicators, but they also had a 27% mortality rate. That's amazing. So those patients actually died from that stress and that pain. So we know treating this pain in our patients is so, so, so important. So we as veterinarians in anesthesia and anesthesiologists and nurse anesthetists, we use opioids to go ahead and treat that pain. And we try to give that ahead of a patient going into surgery. There's been tons of literature to show how this can help us not only prevent that mortality, prevent their pain, but also reduce the need for an inhalant that provides that cardiovascular depression. Sadly, though, the opioids have been found to be problematic with the opioid addiction, the narcotic crises, and many of our opioids have ill effects. In terms of small animal patients and large animal patients too, the opioids tend to cause ileus, meaning they stop normal propulsive activity of the GI tract. We can treat that in many of our patients, but that is a downfall of this class of drugs. And that this class of opioids too in pain relief comes also with an excitability that is more prominent in certain species and breeds, such as cats, such as certain Nordic breeds of dog. As certainly many of us experience, we all take opioids and drugs and we have different effects from that. We also know that the opioids can add to inflammation. So, as a specialty and as an anesthesia specialty, there's been a movement to get away from opioids in treating pain over the last 5 to 10 years, consistent with the opioid crisis that we're having in America. There's been literature out on how to do this. It's been fascinating, but there's two key ways that I'd like to just talk to you about tonight that we get rid of the high need of opioids, not all the opioids, but a lot of opioids in our veterinary patients around the time of anesthesia. The first is by using a local block, a local regional anesthesia. And these local blocks have been phenomenal and not only providing less pain around the time of surgery for our patients, but also, again, improving their first week to two out of surgery, which is fantastic. Equine practitioners, large animal practitioners have relied on local blocks pretty much their whole career. They know how to give them well. And our dentists in the veterinary small animal profession have also relied on local blocks, as have our dentists, our own personal dentists. But we in small animal veterinary anesthesiology, we're just starting to get great literature about how these local blocks can be so positively influential around the time of small animal surgery, especially orthopedic, pelvic surgery, abdominal surgery, body cavity surgery. So it's amazing the literature that's out here about these now. And not only that, the literature not only in dogs and cats, but in exotic species as well. So local blocks, provision of that by the veterinary anesthesiology staff is a large part of our job in treating that pain of surgery. And it's been found to decrease anesthetic mortality, which is an amazing thing in both cats and in dogs, which is really wonderful. Another way that we have reduced the need for opioids is to rely more on aspirin-like drugs called nonsteroidal anti-inflammatories. And there's been amazing information out about this in both our cats and our dogs on how we can use these drugs without ill effect in our patients. And not only that, even in pets with kidney disease and even in different species. So 10 to 15 years ago, we thought that these non-steroidal anti-inflammatories couldn't be used in patients with kidney disease and couldn't be used in certain species. And in fact, it was classic about 20 years ago to go ahead and dehorn a goat or a sheep without any use of a non-steroidal anti-inflammatory. Those patients still had a lot of pain. Now we know we can use these drugs with this research in these species, even if they have kidney disease, and even in species like reptiles. So it's an amazing time for veterinary anesthesiology to have this information out. I'll end this presentation with just talking a little bit about anesthesia in particular species and breeds related to that morbidity, mortality, hopefully easing some fears for you. You know, the mortality, morbidity data is very difficult to discuss because I know it scares a lot of us, but what I'm trying to bring out is that we learn so much from it. And what we've learned is that cats definitely have a harder time with anesthesia. Many of them harbor a lot of disease and we never know about it. Many of them have smaller size, so they're more prone to hypothermia. And getting that tube into their airway and making sure that their fluids are balanced readily is really a difficult part of our job. Cats also have a high prevalence of heart disease. And basically, that's something that's not easy to dictate when a cat comes into you for anesthesia, because many of our cats have heart murmurs. And strangely enough, we have found that many of these heart murmurs are stress induced, about 50% of them. So how can you tell when you have a cat come into you whether they have a heart murmur because their heart is diseased or they have a heart murmur because they're stressed? It's a really difficult thing to do. We try to take into account a lot of the history with that patient. We try to ease their stress as much as possible. but there's been a big variety of literature out there that has proven that if we give cats a preventative dose of something like gabapentin, an anti-anxiety medication ahead of surgery, we really can ease up their chances of having heart problems around the time of surgery. And we change our drug and technique choices based on that picture of heart health around the time of surgery. Rabbits also have a tougher time anesthetically, and many of them develop gastrointestinal stasis as a result of anesthesia or even being in a hospital situation. Their anesthetic death rate is much higher for many, many reasons. Many of them are sicker than they appear, just like cats. But it's also a very difficult thing to go ahead and to attain the right roads into that patient via a vein that we can catheterize and via endotracheal intubation in order to continue our job of anesthetizing them. So we have a lot of great research recently that shows not only can we assess their health and their pain better at home. So again, maybe we can forego the need of anesthesia, but if they need to go to anesthesia, we know how to do it better. But also we can use different techniques in surgery and anesthesia to help their outcome on the opposite side of that anesthetic event. Birds, likewise, we know that they have a lot of hidden disease. We also know that they show stress in very, very bizarre ways, and that their respiratory system is a complicated picture. I was very blessed to be able to work with John Lutters at Cornell when I went to school there and during my residency. Just an amazing anesthesiologist and mentor who just recently put together this wonderful article about the avian respiratory system, but the differences between the different species of birds and their tracheas in particular, as well as their air sacs, really lends to a lot of morbidity around the time of anesthesia. And I think if we had to look back at birds, at cats, at rabbits, and their mortality rate, one thing I can tell you going into anesthesia as an owner, try to assess their health earlier on and make sure that at the first sign of problem, you give a call to someone, your veterinarian, your family vet, to try to figure out what's going on. Because the earlier you get to that, and again, we get that healthy animal going into anesthesia or a little healthier going in, the better off they'll be on the other end. I'll finish by saying we have one breed in particular that I've been asked to comment on, the Brachycephalics, and they come not only in dog sizes, but cats and rabbits as well. These dogs experience a number of different problems peri-anesthetically, just an amazing amount. There's a nationwide survey of the claims put in by them. And many brachycephalic breeds exist, and our dogs in particular. They have what's called brachycephalic airway obstructive syndrome. Along with that, majority of them have issues GI wise. In terms of their nostrils, 76% of their obstruction of air getting into their lungs occurs in their nostrils. That's about 6 to 7 times the obstruction that occurs in a beagle. And 96% of these dogs not only have issues with their airway, but they also have issues with their GI tract because of the extremes of trying to suck air into that oral cavity and get it down into their trachea and lungs effectively. There's been some amazing breakthroughs in terms of peri-anesthetic care in them recently. One of the coolest ones I've dealt with has been that we found a technique whereby we can stop a lot of that post-operative recovery. We call it airway obstruction that occurs in these breeds, whereby post-operatively, because of their big tongue, which is at the bottom of this picture, by the way, that kind of hairy thing that you see, that's a brachycephalic tongue right there. That big tongue can actually get in the way of the glottis, the opening to the trachea in that postoperative period, and all the tissues in this oral cavity of this dog, okay, can actually collapse in on that airway postoperatively. But a way to get around that is to actually tack their little soft palate forward in their oral cavity, just temporarily, so that they have a means to get air in there without sucking the rest of their upper airway into that airway as they recover. So this is just a temporary, we call it a temporary pexy of the soft palate that helps avoid that post-operative recovery period mortality in these breeds of dogs. Another paper that just came out, which is extremely interesting, is that they looked at the effect of clearing the airways on these dogs around the time of exercise, and they found that yes, we can correct many of the airway situations that go on in these brachycephalic breeds, but sadly, we can't stop the endocrine and the GI issues that accompany that airway. Even after these animals are fixed, they still have that unfortunate endocrine and GI issues that go on that create anesthetic issues for us in terms of regurgitation, aspiration pneumonia, definitely adrenal gland and liver disease, etc. So we are learning more and more about these breeds and these species, just a fascinating area. If I had to put a couple plugs in on how to handle these anesthetically and from an owner standpoint, please try to keep these animals thinner. If you hear breathing in them, something's probably wrong because we don't normally hear our pets breathe. But if you hear breathing, get that looked at as soon as you can. And we try to go ahead and decrease their stress if they have to go into a hospital using appropriate oral medications. We have many that we can use now in veterinary profession, from gabapentin to trazodone to some of the benzodiazepines. But the less stress these patients have, the better their breathing is, even with their crummy airways, and the less they overheat. Try to plan these procedures and surgical procedures not in the summer months around times of high heat and humidity, and try to pre-treat them for all the GI stuff that goes with their problems. That will help us get the animal out on the opposite end. I'll finish there. Hopefully we can get some questions, but I want to thank you for joining me this evening, and also thank Michelle and Valeria for their help in putting this together. Really appreciate the opportunity to speak to you all.
Well, thank you very much for that excellent presentation. If you want to unshare your screen, we do have a bunch of questions, um, many good ones. I I think everyone, you spoke very candidly about the risks associated with anesthesia. I think everyone really appreciates that. Are there any questions that you would advise pet owners to ask their veterinarian to better understand their pet's individual situation and risk so that they can feel more confident in a care plan?
Oh, that is a wonderful question. Given the data that we have and given my experience as anesthesia, I would ask your veterinarian two things really. How healthy is this pet going into the procedure? And can we make it more healthy in terms of its heart, its kidneys, its lungs? And also, who's going to be with my pet when the animal recovers? Because we know that's a high time of problem for our patients.
Great. Okay. We actually had a question, some asking about the recovery period, and we can speak about AMC, that your pet is not alone. They're closely monitored, because they were saying, why, people would like to come in and visit them afterwards, but just to reassure them that during the recovery process, they are watched very, very carefully. Um, okay.
Yeah,
So
we have a number of people, individuals, extremely trained and talented technicians and doctors watching that pet in that recovery period.
okay, great, wonderful. Let's see, we also had a question about how does the duration affect mortality? Duration, sorry, that a pet is under anesthesia affect mortality.
Yes, there's a dose dependent reduction, meaning a dependency on the amount of anesthesia that we give pets and the depression that occurs in our cardiovascular system. The longer a patient is under, sadly, it's not that they need more anesthesia, but their organ system really stops responding in the same way. So it's almost like they had more continual anesthesia and higher doses. So we really try to limit the duration of anesthesia as much as we can. Great question.
Great. Um, is there an amount of time that you should wait between procedures that require anesthesia, say a spay and then a dental?
That is an excellent question, and honestly, it's a question that has come up on the specialist listserv, several of them, because I'm on several of them, and it's been more of a question in terms of repetitive radiation that's needed for pets, as well as repetitive surgeries, and we don't know the answer to that. I wish I could say I did, but I honestly can say if the pet is healthy and each one of those days they need to go in for radiation, that's great. That helps us through. But certainly it's an individual type of an answer.
Okay. We had a question. If most deaths occur in between 6 and 24 hours, why do pets often go home after 3 to 4 hours? I don't know if that's a true.
Yeah. Well, that is a great question. We are in the process in the veterinary profession of trying to provide more what we call outpatient surgery for a big reason, and that is infection.
Mm,
Infection happens more commonly when those pets are kept in the hospital. And also their stress level. It's a fine line between going home and getting them out of that recovery period where they're watched, and there's less stress because that can definitely cause just as much problem to those pets. So an excellent question.
okay, great. We have several people saying, "How do you manage the owner's anxiety during this?"
Yeah.
Which is understandable.
Yeah, very carefully, very carefully. And I will say, being a parent, a pet parent, I certainly understand that. We appreciate the healthy respect of anesthesia, and I welcome questions about it to help you.
But can we say though that most pets, at least at AMC, we can say do very well under anesthesia. Fortunately, so yeah,
Unbelievably well. 99% of
okay.
pets wake up from anesthesia and do quite well. But that's because the profession and the subspecialty has evolved to the point that it has. We have had great mentors in our field. I could list many people whose shoulders I stand upon, and I'm grateful to every one of them.
Mm, okay, great. I mean, so basically, be very obviously do your research and go to a place, as you mentioned, with all of these experts. It makes a difference. How is reversal done with birds? That's a question.
A reversal or recovery, I guess.
Let's say
I'll say
reversal. Yeah,
reversal.
recovery, I guess.
Yeah, yeah, reversal and recovery, I hope that's the same thing, but recovery
Mhm.
in birds is done again rather carefully with protection of their wings. We usually recover them with a support of the respiratory system until they start breathing on their own. Once they do, they are extubated, but they are supported in terms of their head, neck, spine, cervical area, and their wings, and then made sure that we can ease up on their keel so that they can move the respiratory system appropriately.
Okay, great. We did have a question similar to the reversal, or if a patient does go into shock, what is done to, I don't know if that's a one size,
Yeah.
but just
Yeah,
what is
during
done to bring
recovery,
them.
if a patient starts showing signs during recovery of lower blood pressure, higher heart rate, loss of consciousness, so kind of a reversal into anesthesia versus a coming through anesthesia, then probably one of the first things that we do is to take a couple of products called reversal agents, which are actually drugs that reverse the effect of anesthesia. And we usually give that accompanied by fluids and more supportive care. So intravenous fluids, more warmth, and those reversal agents. You might ask, why don't we use those reversal agents all the time? Because sometimes the reversal agents can be as dangerous as the original drug that we gave. So we have to be very particular about how we reverse these patients.
Okay. Let's see. What are signs we should look for after taking a pet home after anesthesia that might be cause for concern?
Yeah, that's a great question. And I think probably an altered sign of consciousness or altered behavior, inappetence certainly, is very common around the time of anesthesia. But if that persists within a 24 to 48-hour period, we should know about it. And that's true especially for exotic patients, even for a shorter period, a 4 to 6 hour period. We want that pet to get back on its feet in good consciousness, start eating, drinking, pooping, peeing back to its norm as soon as possible.
Okay, great. What about senior pets? I know you said you can't really say, but specifically they asked about a dental. Are there, certain age that maybe you don't do the dental or?
Yeah, it's a necessary question to
Mhm.
ask because we know that dentals are necessary. The more we reduce the bacterial count in that mouth, the healthier the organs are going to be, right? But I think there's a certain amount of repetitiveness of dental procedures that we have to be weary of. So I try to be more conscious of the regular dentals in elderly pets greater than 75% of their lifespan, and that really trying to be choicey about when we need to go ahead and anesthetize them for that cleaning.
Okay, great. What about a pet with tracheal collapse? Is that a
Yeah,
tricky?
it's
Yeah.
it's definitely an issue, and many of our smaller breed dogs have that as well as cats, and our obese patients have that. So with tracheal collapse, what we try to do is really one of two things. For their procedures, which often involve a stent or may involve maybe a non-tracheal procedure, we try to go ahead and use injectable agents versus gas agents. And we also try to go ahead and intubate them carefully past that obstructive area so that we can get our necessary goods into the patient to keep them anesthetized, but also not bother or irritate that stenotic area of the trachea.
Okay, great. Does a routine dental cleaning use less anesthesia versus a different type of procedure? He said like a spay or something, more involved procedure.
Sadly, no, and
Okay.
that's a crazy thing, right? But the cranial nerves, the facial nerves are highly innervated, even more so than our abdominal nerves. So they are more interactive, more reactive to pain. So dental procedures definitely tend to have to occur at a deeper level of anesthesia. It is rational to have a fear of that anesthesia, but it's also good, as Michelle said, to know that
Mm.
99.9% of the procedures go extremely well because of all the research that I've highlighted tonight. We've learned so much and we're doing such a great, safe job.
Oh, great. I think you were just, again, very, very honest and candid about the risks, which again, we appreciate, but I think we want people to feel reassured as well. But
Yes.
these are all just, very important things to consider. Um, let's see. Many people saying outstanding presentation. I'm sorry, everyone, bear with me. Zoom changed the way that the questions are grouped. Okay, I wanted to be clear. Would you recommend a chest X-ray prior to dental cleaning? I use Xanax prior to vet visit. Would it be helpful prior or Xanax to give gabapentin? I don't know if she's saying herself or the vet, but
Yeah, yeah, yeah.
yeah, prior to dental cleaning to give. And can you actually give gabapentin or before they go in and are going to have anesthesia?
Yeah, the need for the diagnostics such as chest films is really dependent on the individual pet. But I would say a majority of geriatric pets would benefit from what we call chest x-rays and abdominal ultrasound as they age, especially when they are geriatric, because not for anesthesia, but for general health of that pet. And we learn so much from those radiographs, which is great. Do we need them anesthetically? No. Would you give gabapentin pre-anesthetically? I almost can't think of a patient that I wouldn't want to give gabapentin to. And I say that because I don't want that patient as stressed coming into the hospital.
Okay, well, that's all great. All right. Thank you so much, Dr. Looney. This was really such a thoughtful and compassionate presentation, and just for taking the time. As I mentioned to everyone, we will send this out tomorrow. I know that Dr. Looney also will have some resources to share that we'll send out with that, with our email tomorrow. And just thank you all again so much for joining us. I know it's a very a scary subject for people, but hopefully that this, ease your fears a little bit. And again, we appreciate you supporting our programming and we look forward to seeing you at our next event. Again, Dr. Looney, thank you so much. This was fantastic. And have a
Thank
great
you,
evening,
guys.
everyone. Take care. Thank you.